Yeah, what a privilege, and thank you very much, Julia, for your very generous introduction. And this is such a great title, Psoriasis Research, Progress and Future Directions, because I think from this morning and Andrew's talk, you must have had a flavour for how there's been an absolutely extraordinary shift in how we manage psoriasis, certainly in my professional lifetime. It's just changed absolutely completely. And that has been really, really driven by research. Research has underpinned all of that progress, and is one of the reasons I feel excited about getting up in the morning. I've had such a wonderful, wonderful career, which I have absolutely loved. And so this era of advance in management is something that is been exciting to see. And just to tell a very short story about the generalized pustular psoriasis story, because that went back to 2011, and Jonathan Barker, my consultant colleague, came to me and said, Catherine, there's this new Whiz genetic sequencing technology, and it's able to look at the genes in rare disease, because we've just been looking at common disease. Generalized pustular psoriasis, it's a perfect rare disease, high need. Go and find some patients. So my job was to go through the notes of all the people that we'd had at the Institute with severe generalized pustular psoriasis. And you can tell from the notes that these people were high burden patients coming backwards and forwards in and out of hospital. And so out of our cohort, I chose 5 patients who were as similar as I could tell in all of their characteristics and their disease course. And we contacted them, and those patients generally get generously consented to the research. And in fact, it was the sort of predecessor to BSTOP. We took their blood, we looked at their DNA, and found in 3 of those patients that they were carrying this abnormality in a gene called IL-36RN. And I tell you, it was super exciting to think that this might be a driver mutation that was causing this disease. And as Andrew said, at the same time, a group in Paris, our paper was published in September, theirs was published almost the same month in another journal. And the drug companies went away, produced a drug that targeted that pathway, and those patients were given it. And then there was the proof. This gene was the gene that was actually driving the disease. And then, as Helen said, this has just been approved by NICE. And I would say to you all, being members of the Psoriasis Association, the role of the Psoriasis Association was absolutely fundamental to getting that drug approved. The power of patient advocacy is so important. And also a shout out from Darren's work, but also the other study that the Psoriasis Association have supported is a PLUM study, and we provided data as well to underpin the cost effectiveness modelling. So this really sort of exemplifies how research can ultimately lead to really better outcomes for patients. So now, where are we? And as Andrew said, we do have these unbelievably effective targeted therapies which render the skin clear or almost clear. And for most people, these treatments are very safe. If you look at the whole population across Badbeer, and we've got 16,000 odd patients in that, the absolute estimate of a serious infection, which is the main thing, is about 1 in 1,000. So, that means 999 patients are absolutely fine on these drugs. So there are a few nasty side effects, but they're rare. So we have these incredibly effective treatments that are really very safe for most people. But we have this too little, too late problem. For NICE, these treatments are only approved for people with severe disease and only right at the end of the treatment ladder. And as we've heard from some of the audience today, most people either aren't getting onto that ladder or are put off even starting it. So this is a really a big problem. And we also know even in those patients who do get into healthcare, who would qualify for these high-cost drugs, only a fraction of them are actually getting them for whatever reason, a plethora of reasons. But only 5% are on a systemic therapy, so the old-fashioned one, and 0.7% on a targeted. So we're really seeing a tiny fraction of the people who could benefit from these treatments aren't. So we have people being treated far too late in their disease course, which inevitably leads to a cumulative lifetime burden, which, if we intervened early, would be avoidable. Quite apart from your question about whether intervening early prevents the comorbidity burden, we know that the sooner you have your treatment of psoriasis that's effective, you feel a whole lot better. So setting aside the comorbidity problem. And the other thing is that everybody's treated the same, and that's true also in the cost-effectiveness modelling, which makes these drugs very high cost. And also our treatment approaches don't take into account individual variation in lifestyle, environmental factors, your genetics. So it really is a rather crude approach that we're taking in psoriasis. And we do need to do better, and if we did better, intervene early, outcomes would be a whole lot better. So just to flag up Julia's point, I mean, the Psoriasis Association have really been integral in developing this bioresource, the BSTOP study. And the fundamental point of this study is to understand psoriasis better and to develop better targeted, precise tools to improve things for patients. And just to flag, we've got nearly 10,000 patients. That's more than 6 million data points, a lot of data, lots of samples and lots of outputs, all of which are on our website, so please do have a look. But this resource, along with others, has really underpinned some of the things I'm going to talk about now. So first of all, does intervening early really make a difference with these treatments? Does it actually make a difference? And this is a hot topic, and the evidence is emerging that maybe it does. One study, which was funded by the pharmaceutical company, called the GUIDE study, has got a lot of airtime because this has been a sort of hot topic. And this study it's got limitations, but it does suggest that earlier intervention may make a difference. So they took a cohort of over 800 patients, treated them all with this highly targeted treatment, and then looked to see what the determinants were of whether somebody was going to be a super responder. In other words, were they going to get clear skin? And they looked at a whole load of variables and stratified the population into whether they had disease for 2 years or less or more than 2 years. And the first thing to say is that actually everybody who got this drug, however long they had psoriasis, did pretty well. So as Andrew said, for most people it's really very effective however long you've had the psoriasis. But what they did show also was in those patients who were likely to be super responders, if they had their disease for a shorter period of time before they got the treatment, they were going to probably do better. So it supports the notion earlier intervention is helpful. And so if the patients had a lot of treatment before they got to this treatment also, that seemed to influence outcomes. But it does suggest that there would be a lot of benefit in identifying markers of people likely to go on to get a more difficult disease earlier, before they actually do. So we need better tools, because a lot of people get psoriasis. Not everybody goes on to have more impactful, difficult disease. So we really do need a marker of who is going to get more severe disease so we can screen the population of people with psoriasis. So that's something that we've been interrogating as part of this big project called BioMap, which is a multi-partner European consortium which the Psoriasis Association have been part of, trying to ask the question, can we develop and understand the mechanisms that drive more severe disease? And one of the ways we looked at this was to look at the genetics and try and understand the difference between genetics and lifestyle and what drives more severe disease. And we looked at very large-scale, population-based data sets in which we had information about the psoriasis as well as other lifestyle variables and their genetics, the patient's genetics. And this was part of something called the Skin Genetics Consortium, which is again a sort of global effort to align and curate all of these population-based data sets. And we looked at 43,000 individuals with psoriasis from these 4 countries and looked to see the extent to which your genetics versus lifestyle was important in predicting more severe disease. And we already know that there are around over 100 areas in the genome that make us more susceptible to get psoriasis. And so we asked the question, well, were those areas also important in determining some more severe disease? And they are. So the more of the so-called genetic burden you have, the more likely you are to get more severe disease. And that goes with the idea that we know earlier onset disease is also often more severe. And what we also found is that that genetic, what's called genetic liability or genetic burden, is as important as lifestyle factors. The lifestyle factors that we looked at, and this is where things like my skin become incredibly important. We only had very top-line information, but we found that, for example, smoking again and body weight, particularly around the middle, is particularly important in driving disease severity. So this genetic risk can be quantified and potentially used as a prediction tool in people with psoriasis before they go on to get difficult disease, and it could be used to stratify the population and perhaps fast-track people in for management. The second thing we've been interested in, and it came up briefly, is to try and understand this connection between psoriasis and cardiovascular disease, because again, would treating psoriasis earlier prevent the cardiovascular problems? But you have to know that the psoriasis is driving the heart problems, for example, and you need to understand that. But actually, as I said earlier, it looks like it's rather a bit more complicated than that. And in fact, it is the genetic determinants of heart disease are also the same as psoriasis. So there's a shared biology there, if you like. And that from this work, you wouldn't necessarily predict or expect aggressive treatment of psoriasis per se to reduce your cardiovascular risk. I think that's an important point, and that more information and research is needed in this area. The other side of the coin is that we have this whole raft of people who are doing really, really well on their treatment. They have clear or nearly clear skin on drug. How do we keep people well, and do they need their drug, for the rest of their life? Because people don't want to be doing that if they don't need it. And we know from bad beer, and this is again, Andrew showed this plot, but the probability of, this is about probability of remaining on the drug. And of course, a lot of our focus has been on trying to understand those people who don't do so well and come off their drug, have to change their treatment. And that's all been all the focus. But of course, this, if you look at the y-axis here, if you look up here at the top left-hand corner and they say the orange block of the people, there's a whole block of people there who are still on drug, doing really, really well, but they're still taking their drug. They're still needing to be on the therapy. And so we've been interested in trying to understand, well, how can we keep people well controlled, and do they really need that drug? And one thing we do know is the amount of drug that you've got on board is very important in that. And one of the reasons that treatments fail is because of this phenomenon called anti-drug antibodies, and that is well established. But actually, we've been interested in trying to understand, can we minimize the amount of drug for a person, either give them more or less, and certainly try and avoid giving them too much. Because we do know that the way these drugs are developed is the dosing is based on the population. And because these drugs are very safe, the dose can actually be pushed up quite high. So we know with biologics that the dose required is at the top of what's required so that the bigger population respond. So that means that some patients are probably getting more than they actually need. And so this is approach now to really individualize the amount of drug that a person gets based on their individual characteristic. And this is called model-informed precision dosing. The blood sample is taken, and then we run a model, and that tells us how much that patient actually needs for them, not for the population, but for them. And this is a strategy that we're exploring in a trial, and my colleague Satvir Mahil is leading on this, to try and really develop approaches that mean that it's just amount of drug for that individual patient. And she's looking at a population of people with clear or nearly clear skin on a drug, on a biologic, risankizumab, and she's randomizing them to 3 different options. One is they just take the drug when they want it, when they need it. When their psoriasis pops up, she takes it. The patient is led to take it as they require. The second is that we develop their individual drug dosing, and this is you fill in a little all the information there for the patient about their dose, when they last took it, and so on. That comes up with the dose for that patient. And then the third option is, it's running now, but anyway, yeah, so it comes up here on the right, that number of weeks, so that patient only needs to take it for so many weeks. And then the third is continuous standard of care. And so the other element to this trial is really trying to empower the patient. So all of this information is in our MySkin app, which walks you through your journey on this treatment, asks about how your psoriasis is, reminds you when the treatment is required, and also there's an integrated so-called PIFU. So if you're in trouble, you can just flag through the app and get seen that week by our team. And this is really a model system for getting the right treatment at the right time. And although we're testing it in a population of people with clear skin doing well, it's a generalizable model and proof of principle that this is really the way healthcare should be going. And it's good that Wes Streeting is of the same mind. He wants to get people out of the hospital to the community. He wants us to prevent sickness, and this is all about earlier intervention. And he wants us all to go from analog to digital. So it's very good when your strategic goals align with your government. It means that he'll give us lots of money to do it. But I think that it is where we want to be now, that we have these treatments that are so effective. And yet only a fraction of patients are receiving it. So it is absolutely timely to be taking these things. And the model we have in psoriasis is this, that we have a whole stack of people in the community not accessing the care that they need. They're trying to get to see their GP, and only a few of those people are getting to see the specialist. I mean, the number of referrals on the waiting list to be seen in dermatology between 24 and 25 is well over 1 million, and the number of bookings in dermatology is 250,000. So there's this massive disconnect between demand and capacity. And the other problem is our whole healthcare model is very healthcare professional centric. So we do need these sorts of innovations and research, such as the PLAN trial. And so patient empowerment, holistic, personalized assessment. This is what we're doing already with the MySkin app. In time, and blood sampling, which you might have been seeing, you can do your self-sampling in time, and with more research, we'll be able to integrate images, maybe your DNA, other key lifestyle factors driven by AI. It's all coming. It's really, really exciting to get a very precise assessment of what your treatment path should be. And then you might need to go, it might tell you, yes, you need to see your GP for this, or other healthcare providers, or go to the pharmacy, or self-referral, direct to see the specialist if your self-assessment shows that you've got disease that requires systemic treatment. And actually, we are trialling this strategy. As was mentioned, it's at the quarter 2026, so the app will be launched at the end of this year. And then we are launching this strategy for direct self-referral to for rapid access to systemic therapy for psoriasis for the more severe, and triaging and advice and guidance to other healthcare providers if a specialist intervention isn't required. And so the vision is that most people with psoriasis won't be some amorphous mass of people not getting the care they need, but they're going to be individual people doing well with the information that they need, and they'll be getting the care that they really require at the proactive, precise, timely care, treatment at the right time. So to thank everybody involved in all the research that we do, but in particular all the people with psoriasis who have participated and donated their time and samples, and of course the Psoriasis Association, who've really been absolutely fundamental to what we do. Thank you.